across, and we have Dr. Hello, and you have Dr. Kennedy, who is one of the people who has learned these techniques over on this side of the Atlantic and transported them into North America. John, your turn has come to talk to us about posterior ankle arthroscopy.
Well, thank you very much, and I too have many crying patients like Dr. Van Dyke, but I think probably for different reasons. Let me start here by just going through my disclosures, and we'll talk about the reasons for posterior ankle arthroscopy. We know that there's both osseous and soft tissue pathology, and both intra and extra-articular pathology, and Pao has gone over this very elegantly earlier on to show us the os trigonum, the Stita process, and indeed osteochondral lesions both within the subtalar and ankle joint. The soft tissue pathology we see is gross cicatrization around here. There's a lot of scar tissue that can form, particularly in basketball players, runners, and ballet dancers, and so forth. So we see flexor hallucis pathology. Bill Hamilton has shown us that in open procedure several years ago, even the perineal tendons that Professor Van Dyke has talked about, and then, as I said, the impingement. So how do we diagnose it? Well, not only on clinical examination, but also by radiographic techniques. And the simple sagittal or lateral X-ray will help us identify any bony pathology. And an external degrees of 25 degrees can help us differentiate whether there's a true fracture or not through that Stita process. CT and MRI are also useful. MRI is very useful for intra-articular pathology, such as OCLs, and for soft tissue impingements. But I think I found in the era of healthcare cost containment that ultrasound is probably the best modality for me to identify soft tissue pathology and to be diagnostic with selective injections, and occasionally therapeutic with selective injections in this area. So if we look at posterior arthroscopy, in fact, it's a fairly new or young procedure. Rick Ferkel, on this side of the Atlantic, first described the posterolateral portal, which I still use. I find it very useful. Nick, who has just left us, then described the prone position, the two-portal prone position, which is probably what most of us are talking about today. And that was only in 2000, and then we found our first case reports of this from the Egyptian group over in 2006, which showed good clinical and functional outcomes. Now, this is the two-portal technique, and Pao and Nick have gone over this, so I won't belabor it, but effectively we find the lateral malleolus and draw a line parallel to the floor and perpendicular to the Achilles, and from that we can identify then the lateral portal 5 millimeters away from the tendon itself. That should avoid the sural nerve at this level. And then you make your incision, being careful with the mosquito clamp in line with the first web space. I err on the side of just a little lateral to that first web space when I put the probe in. Then you introduce your trocar and a 4.0 scope, and then you make your second incision on the medial side, aiming for the scope and then downwards onto bone. And it's that old orthopedic maxim, get onto bone quickly and we can do little or no harm. So the first series that Dr. or Professor Van Dyke looked at, again, as functional and clinical outcomes were excellent at 36 months in a 55 patient cohort. Now, Professor Mafuli has also shown in those cases where you have both in anterior pathology and posterior pathology, doing a front and back scope can be quite difficult, not only in terms of timing, but in terms of draping and complications associated with infection and so forth. So this is a nice adjunct to an anterior arthroscopy using two posterior portals, and he's identified, along with Francesco Allegra, the posterior medial portals, and this area, this triangle where it is an aneural area, and he'll probably describe that a little bit later on in his own talk. But again, excellent functional outcomes using that. So why do we do this? Well, it's not just fun, as Professor Van Dyke said, it's also very useful. When we look at the open versus arthroscopic treatment in the collaboration between Professor Van Dyke's group and our own here at HSS, we did that in a systematic review. There were over 300 studies that we looked at, which we were able to cull down to 16, looking at the complication rates. We found that the open were far greater than the arthroscopic complications, in fact, twice as much. More importantly, the return to activity for sporting people is just 11 weeks on average versus 16 in an open procedure. So I think this is an exciting area, and I also think it's practical in terms of patient satisfaction and cost containment. What we didn't find was any sort of systematic approach to this procedure, and somehow this is, there we go. Hopefully this will start the video. Like Dr. Galano says, I think the first thing to identify from the lateral side here, running right across, is this intermalleolar ligament. And this divides the joint in two equators. And you just saw there that the, just move on to the next slide, we'll see it. This is, I hope this is the slide. In any event, this ligament then divides it in two. And now we're looking at for some reason, we're looking at the second quadrant, which is the supromedial quadrant. We're looking at the flexor hallucis longus in this area. We typically start in an anti-clockwise direction on a right ankle and clockwise on the left. And for some reason, this other video does not seem to be working. Here we go. So this is the PTFL on the supralateral quadrant here. And then underneath, or deep to that, is the transverse ligament. And I think it's important to look at that carefully, particularly in case of the posterior impingement. We then move on, as I said, to the supromedial quadrant, where we look at the flexor hallucis longus and debride any muscle belly that may be low-lying or any degeneration there. We now go to the inframedial quadrant, where we can see the os here has been removed. I use a small little osteotome to do that, and then just finish it off with a rongeur. At all times, of course, being careful that just medial to this is tiger country, which we want to keep well away from. And then we finally go to the infralateral quadrant, where we can see the CFL ligament, and if necessary, then we can also go and have a look at the peroneal tendons at this point. So this was a systematic review of the soft tissue or extra-articular pathology. We can then go through superior to the inframalleolar ligament, particularly starting on the medial side and looking then over on the lateral side of the talotibial joint. And similarly, then we can go inferior to this, to the ligament which divides it in two into the subtalar joint. Obviously, we're just going to see mostly at this point the posterior facet of the subtalar joint. So using this systematic review, we looked at 22 patients who underwent arthroscopy, and we just want to go back here. Most of these involved an ostrigonum, 2 involved a steatoprocess. In every single one of those cases in which there was an ostrigonum or a steatoprocess, there was some form of FHL pathology. And I think it's important just to underscore that when you're in that supromedial or inframedial portal, that you follow the tendon down into the tunnel, and that you flex the FHL by extending and dorsiflexing and plantarflexing the tendon itself. In any event, our results showed that both the functional outcomes in SF12 were improved, and most importantly, the mean return to sporting activities was 12 weeks. And that was probably confounded somewhat by one patient who had an infection, and it took him several months to get back. The median range here was about 8 weeks. Complications in this was one infection. This was a basketball player who had a very large osteogonum. He had multiple steroid injections. We required a larger incision to take this out. And this was a case where I agree with Dr. Saxena. When this happens, you have to make a bigger incision and the skin is poor. That's, in retrospect, I should have immobilized him. I didn't. He moved very quickly, and of course the wound broke down, and that was a case of crying in Dr. Kennedy's office. The other patient was a dysesthesia of deep peroneal nerve, which is probably not related to the surgery, but more to the anesthesia. So conclusions, I think our results are comparable to the current literature. Return to activities is within 12 weeks. Again, to underscore FHL pathology, you have to look for it every time that you have a steder and ostrigonum, and that it's complex, the anatomy back here, and you really do need a systematic approach to help guide the surgeon. So that's it from New York. Thank you very much.
Okay, thank you very much, John. Thank you very much for having summarized so clearly what can and cannot be done through this approach. Now we don't have any questions from the audience. For the sake of time, I think that from the posterior, there's Pietro Spennacchio who's asking, what do you mean for soft tissue posterior impingement?
I think for soft tissue impingement, typically it's from this inframalleolar ligament or this Roulier ligament, which is lying just beneath this. I think when you this is lax in plantar flexion and it becomes taut or tight in plantar flexion. In an injury which is a hyperdorsiflexion type injury, that will tear that ligament, and obviously with scarring and cicatrization in there, we'll get fibrosis. And then on the plantar flexion, it's like a nutcracker effect. So I think oftentimes when we see an ostrigonum or a steder process, we think that's the cause of the pathology, and it may well not be. It's usually soft tissue back there. I think that is the true cause, getting caught between the bone.
Okay. Moses Kimani is asking whether we can use a burr to remove the ostrigonum or the steder lesion. What I normally do is I use the burr to remove the steder lesion, and I try and remove the ostrigonum, as a whole. What do you do?
I'm a little worried about a burr in that area. I think that so much of it depends on the instrumentation you use. When you're looking at a burr, you need to be very careful that you see the entire part of that burr that's rotating. Because if you concentrate just at the tip, you don't know where the proximal portion of that burr is, and it could well be burring out your nerve for you. So I would much rather use an osteotome, which is controllable, and you can then take out the steder or the ostrigonum at that point. And if necessary, then you can go in and use a bone cutter or shaver. It's 5.5. It's pretty big, but it really does protect your soft tissues and isn't as likely as a burr to pull in those soft tissues. So I'm very, very careful using a burr in that area.
Okay. Amol, what do you do?
Yeah, I agree. I like to use a shaver, and there's some nice arthroscopic rasps, and I like the small osteotomes. I like to be able to see everything that could cause damage. I like to be able to visualize that posteriorly, especially.
Okay. Well, I think that the burr should be, one should be very careful in using a burr. I use a fairly aggressive shaver, but that's all. Anna King is asking whether we perform essentially scarification, sort of longitudinal tenotomies arthroscopically, and if so, do you perform one or various cuts? I mean, I must say I don't use endoscopic techniques for my Achilles tendon, but John, do you?
Yes, I do, and I think this is a really terrific question because this whole controversy about orthobiologics and so forth with PRP, one of the things that we've been doing is using perineal tendoscopy, posterior tibial tendoscopy, and Achilles tendoscopy, and not just doing a denervation that Nick talks about, but actually looking for the pathology within the tendon when we can find it, and debriding the tendon, and at the same time introducing a biologic from the patient, typically PRP, into that area. So I think that adds an adjunct to the mechanical aspect by introducing a biological, and we have good data now going back 3 years, and hopefully we'll be we're presenting that, and hopefully we'll be publishing that soon. But just to give you a forerunner of what that data shows, around 70% of patients will get better using that combination of debridement and biological adjunct. What we need to do is do a head-to-head trial to see what the control of just the debridement alone would be, or what the PRP would be. And of course, that's a randomized control trial. That's a different step. But just for an initial study, this will show nice data.
Okay, thank you. Now, last question: how do we diagnose posterior impingement and osteogonum Italy?
Clinically, this is typically found in the ballet dancers who are going on point or demi-point, or in soccer players when they strike the ball. It's a hyperplantar flexion is the cause of this posterior impingement, is the cause of the symptoms. The cause of the initial injury is a hyperdorsiflexion usually. So it's a history and a clinical examination, followed then by selective ultrasound-guided injection into the area. Typically gives you a very good idea. And of course, if you're not sure, then an MRI can be helpful.
Okay, fine. Thank you very much, John. We're now going to move to the other side